and thank you for joining this ONC Live peer exchange titled Expert Views on Therapy for Ovarian, Fallopian Tube, and Peritoneal Cancers. As you know, ovarian cancers remain a very challenging disease. Most are diagnosed with a late stage, most recur, and patients are receiving more and more treatments that are complex, but fortunately, new treatments are available. It's my pleasure to remind you that we have had 3 new FDA approvals for targeted therapies in the last 2 years, and I anticipate within the next year we'll have 3 more. So this is an exciting time, novel therapies, our armamentarium is growing, and our paradigms are changing. And it's my honor today to be joined by my friends and colleagues from all over the country. I'm Brad Monk. I'm a gynecologic oncologist and professor at the University of Arizona and Creighton University in Phoenix, Arizona. Joined here to my left is Dr. Robert Coleman, Vice Chairman and Director of Research from MD Anderson Cancer Center. Welcome, Rob. I'm also here with Dr. Tom Herzog, Associate Cancer Center Director at the University of Cincinnati, also a gynecologic oncologist and professor. Welcome, Tom. And then Dr. Kathleen Moore. Dr. Moore is from the Stevenson Cancer Center at the University of Oklahoma, also a gynecologic oncologist and a phase 1 expert. I love it. Thank you and welcome. And then Dr. Angeles Alvarez-Secord, professor in the Division of Gynecologic Oncology at Duke University School of Medicine in Durham, North Carolina. Angeles, welcome.
Thank you for having me.
You're welcome. So we have a number of segments today, and I couldn't be happier. As I said, the paradigms are changing, the therapies are more diverse. We have novel approvals that have just occurred, 1 just recently, and then ultimately 3 that are probably around the corner. I'd like to talk about, though, the different subtypes of epithelial ovarian cancer. So the title of our program is Ovarian Cancer, Fallopian Tube, and Peritoneal Cancers. It's really one entity. But Rob, we know a lot about the different subtypes. Even though they're different organs of origin, tell us about the different subtypes of epithelial ovarian cancer.
Yeah, I think it's a good lead-in because I think we've all known for many years that there are morphological differences looking at these cells under a microscope, right? That the histologies can vary from the most common type, the high-grade serous tumor, through a variant that we think is really a different disease called low-grade serous, clear cell, endometrioid, mucinous. And they kind of are distinctly different from the way they look. But it's interesting because the molecular information that we've now subsequently learned from the TCGA and multiple other data sets, delving into these histotypes even more, we're finding out that they actually can segregate even within cells that all look the same. Right. And I think that's where a lot of what we're going to talk about is kind of starting to stem from. So we have these new launch points that identify these subclassifications that where therapies might be develop into a better outcome or a better expectation based on those.
So about 85% of our cancers are these high-grade serous cancers, 15% and sometimes high-grade endometrioid, and those are pretty homogeneous. But then low-grade serous, clear cell, and mucinous cancers really are a different entity. So Katie, do you treat those low-grade serous, mucinous, and clear cell cancers differently, or you just heard Rob says they're not the same.
Right.
But so you treat them differently, right?
We know they're not the same. Currently, standard of care would still be to use the same chemotherapy backbone, although there are clinical trials in development. We've completed some in mucinous, which unfortunately didn't lead to a different standard of care, but we're still looking. For low grade, there's discussion of using different agents in the frontline, actually moving away from platinum and taxane-based frontline therapy and using more targeted therapy, because we know that chemotherapy doesn't work. We're too nervous not to use it. We're finally getting brave enough to run a clinical trial that's going to test whether or not those patients need chemotherapy at all.
So, Angeles, I think what I heard is you don't want to treat them the same, but you do anyways? Is that what you said?
I think that's an accurate statement. That
was Katie.
and then, right, but Angela, so how does that change the prognosis?
So the prognosis between these different subtypes is certainly variable. So high-grade serous patients tend to have the worst prognosis compared to those with low-grade serous cancers. low-grade serous cancers tend to act in a more indolent fashion. Patients with early-stage mucinous and clear cell tumors and low-grade endometrioid cancers tend to do better, but patients with clear cell or mucinous advanced stage disease tend to do much worse. But I want to drill down even farther into the high-grade serous tumors. Even within that entity, as Rob was mentioning, there's different classifications. And one of the big ones seems to be whether or not that tumor harbors a homologous recombination defect. And the most common HRD tumors are those with germline or somatic BRCA mutations. So we can drill down even to that group, and you were asking about prognosis. And that group of patients that have high-grade serous ovarian cancers and have mutations in these genes, their prognosis is much better compared to women who have non-BRCA mutated tumors.